Good evening, everyone. Welcome to the Ohio Health Cancer Prevention and Wellness Series today. My name is Dr. Deepa Halaharvi. My pronouns are she and her. I'm a board-certified surgeon with MD Anderson Network-certified physician practicing at Ohio Health Grant Medical Center, Ohio Health Dublin Methodist Hospital, Ohio Health Riverside Methodist Hospital, and Pickerington Medical Campus. I'm also an Associate Program Director of the Breast Surgery Fellowship at Grant Medical Center. I completed my residency in general surgery at Ohio Health and fellowship at Grant Medical Center. Whether you are a cancer survivor or someone who has not experienced cancer, this series is for you. This is for you to understand and reduce your risk of cancer and also increase your overall wellness. This will be our second virtual live event exploring the breast cancer risk and diversity. Joining us later today, we have Dr. Lucy Bucher. She's DOFACOOG. She's board certified in obstetrics and gynecology. She completed her residency in obstetrics and gynecology at Ohio Health Oblenis Hospital in Athens, Ohio, and she practices at Oblenis. She's also a Senior Director of Medical Affairs and Medical Director of Women's Health at Oblenis. We are so very excited to have her join us, and she'll be joining us for our Q&A session after this evening's presentation. My objectives today are identifying breast, chest cancer risk factors, contributing factors for disparities in breast cancer in African American women, LGBTQ population, and immigrants. I'm also going to talk about a recipe that I created to decrease the disparities. We will identify opportunities to prevent breast and chest cancer. We're going to review current screening recommendations. So please post any questions you have in the chat, and we'll answer those in the Q&A after the presentation. So in the beginning of my presentation today, I want to start with a story. It's a story of health equity story. It's actually by American Cancer Society, and it's on YouTube, and we will put the link in the chat for our audience to save and watch later. No matter the color of your skin, where you live, who you love, or who loves you, anyone can get cancer. It does not affect everyone the same way. It is unfair and unequal. Where you live shouldn't determine when you live or how long you live, but it often does. I would like you guys to meet Jenny and Marianne. Jenny is the Caucasian girl on the left. Marianne is African American on the right. They've been best friends since elementary school. They rode the same bus, loved the same dances. Years later, they're both diagnosed with breast cancer, devastated by the news. But our research shows that Jenny has better chance of survival. African American breast cancer patients are 40% more likely to die of breast cancer. Where people live, work, or grow greatly impacts their cancer experience. Jenny lives in an area where there is quality health care, affordable healthy foods, and reliable transportation. Marianne is a different story. Due to generations of discrimination, her community has limited or no access to those options. Marianne won't have the same opportunity to screen, prevent, find, treat, or survive cancer. African Americans have the highest death rate, shortest survival of any racial groups for most cancers. Research also shows that the LGBTQ population has greater barriers to care due to homophobia or transphobia, which can prevent early detection of cancer, and the disparities keep going on and on. At the end of the day, access to health care shouldn't be a privilege, but it should be a right. Breast cancer is the most common cancer worldwide. In the United States, 1 in 8 women will develop breast cancer in their lifetime. Looking back at 2020, there were 1.8 million new cancers were diagnosed in men and women. Prostate cancer being the most common cancer among males, lung cancer being the second most common, and colon cancer being the third most common. Looking at the female gender, the most common cancer is breast, followed by lung, and then colon. And when we look at the death rates, the most common cancer for both genders is lung cancer, followed by breast for women, prostate for men, and colon for both genders. And looking at the lifetime risk of breast cancer worldwide, women who live in developed countries tend to have higher lifetime risk of breast cancer than women who live in developing countries. Although we don't know all the reasons for these differences, lifestyle and reproductive factors play a large role. Low screening rates, incomplete reporting can make these rates, breast cancer in developing countries, look a lot lower than they truly are. And that can also experience some of the difference that we see. Breast cancer in the United States in 2021, looking at the numbers, there's 282 approximately new cancer cases in women, about 2,700 in men, and 50,000 women will get diagnosed with non-invasive cancer, and unfortunately we'll lose about 45,000 men and women to breast cancer. It is the second leading cause of death in women. And looking at worldwide, in 2020, there were over 2 million new breast cancer cases that were diagnosed, and unfortunately we lost 700,000 people to breast cancer in 2020, and that's worldwide. So before we delve into this topic, I would like to talk about risk factor. A risk factor is something that may raise your chance of getting the disease. That does not mean you will get the disease. So gender, being a woman puts you at a risk for breast cancer 100 times. And hormone replacement therapy, this is the combination of estrogen and progesterone that women take as they're going through menopause. If they take it for more than 5 years, that can increase the risk of breast cancer. This is also important for transgender female or transgender women who take hormone replacement therapy for more than 5 years, can put them at risk for breast cancer. And for transgender men who take testosterone that gets converted into estrogen, that can also increase the risk of breast cancer. Looking at the race, most commonly breast cancer is seen in Caucasians, but it's very aggressive in African Americans. Increasing in age as we get older is a risk factor. Having a personal history of breast cancer is a risk factor. Having a first-degree relative doubles your risk of breast cancer. And an atypical breast biopsy, such as atypical lobular or ductal hyperplasia, can also increase your risk of breast cancer. Obesity is a risk factor because the excess fat stores estrogen, and that's a risk factor. And unfortunately, having dense breast tissue is a risk factor for breast cancer. Looking at the menstrual history, women who have early periods less than to age 12, late menopause over age 55, or late first pregnancy are all risk factors. That's because you're not breaking the estrogen progesterone cycles, the menstrual cycles. And so therefore, pregnancy and breastfeeding, which breaks those cycles, or protect you against breast cancer. Nulliparity, meaning not having kids, also is a risk factor because, again, you're not breaking those cycles. And history of radiation in those people who've had radiation, mantle chest wall radiation for non-Hodgkin's lymphoma is a risk factor. Tobacco and alcohol abuse are risk factors amongst many other cancers and breast cancer. In genetics, 85% of the time, patients will not have a family history of breast cancer. That just tells you 85% of the time cancer is sporadic. And that's important to remember when you're getting your screening mammogram. Some people don't want to get it because they don't have family history of breast cancer. Looking at the race and gender, Black men have highest breast cancer incidence and also highest mortality or highest death rate compared to Hispanic men. And looking at the African American women, they get diagnosed with breast cancer much younger than the Caucasian counterparts. The median age of diagnosis is 59 for African American women compared to 63 for white women. Ethnicity and breast cancer. When you're looking at Hispanics and Latino women, the number of new cancer cases and death rates are lower than the Caucasian and African American women, yet it is the most common cancer and leading cause of death in that group. They do get diagnosed later due to lower screening rates and delays in follow-up after an abnormal mammogram. They're also less likely to get good quality care. Looking at Asian Americans and Pacific Islander women, new breast cancer cases are lower, and it's a second leading cause of breast cancer-related death. American Indian and Alaska Native women, there are new breast cancer cases, and they vary depending on where they live. But typically in Alaska and Southern Plains have the highest rates, East and Southwest have the lowest, and it is the second leading cause of death for them. Looking at the new immigrants to the United States, they tend to have breast cancer rate close to the countries they migrated from. However, their daughters and granddaughters of immigrants tend to have risk close to women born in the United States. African Americans are the second largest racial ethnic minority group in the United States, following Hispanics, and it's also the most common cancer among the African American women. 1 in 9 women will get diagnosed with breast cancer in their lifetime. So what are some causes of these inequalities in this group of population? There's social, economic, cultural differences that affect cancer risk, access to high-quality health care. There's also socioeconomic disparities, results in unequal access to opportunities and resources such as work, wealth, income, education, housing, healthy food, and overall standard of living. In the United States, 25% of the African American women live in poverty compared to the 11% of Caucasian women. Same thing with the insurance. There's a lot more African American women that have no insurance and unemployed compared to Caucasian women. This is also has to do with a number of different features that we'll talk about. Breast cancer and disparities in African American, they have higher mortality, higher death rate, and I'll get into that in just a little bit. They do get diagnosed at much later stage of breast cancer. They get diagnosed at much younger age. There's increased adverse tumor features that are noted in this population. There's also higher obesity and higher incidence of male breast cancer. And again, obesity is where there's excess fat, and fat stores estrogen, which increases the risk of breast cancer. When looking at the biology of breast cancer in African American women, they do get diagnosed with more inflammatory breast cancer and more triple-negative breast cancers, which means they lack estrogen, progesterone, and HER2/neu receptors. These usually have poorer outcomes as effective treatments have not yet been developed. The tumors tend to be clonally diverse. They're very difficult to treat. And so genetics also plays a huge role in this group of people. 40% of the time there is a genetic mutation. So breast cancer death rate is 40% higher in African American women than white women. And that is due to advanced stage at the detection time, problems in high quality health care, fewer screening mammography, lack of timely follow-up, greater triple-negative breast cancers, differences in makeup of the tumor, barriers to high quality health care, such as not having insurance, and risk factors as being overweight, and of course health behaviors, and not just being compliant with what's being told by their primary care physicians or their specialists. There is also higher prevalence of health conditions such as diabetes and hypertension, which accounts for survival differences in this group. And diabetes significantly increases the risk of cancer death, and it's more prevalent in African Americans than any other racial and ethnic groups. As African American and ethnic minorities are underrepresented in clinical trials, and this is a really important point to pay attention to, because we have to take advantage of these clinical trials that are offered to us. Otherwise, it's very difficult to assess the efficacy of cancer therapies. African American women also are less likely to undergo preventative care. National Cancer Institute noted African Americans less likely than Caucasian women to have genetic testing, taking medications to protect against cancer, to undergo prophylactic surgeries, and they're really not likely to have trust with their physicians. And they're also more prone to get diagnosed with breast cancer under age 40. Just today in my office, I saw a 35-year-old African-American woman who came to me after feeling a breast mass, because there are really no screening guidelines in this age group. So good thing that she did a breast exam and found a mass, and unfortunately she'll most likely be diagnosed with breast cancer. And sadly, African Americans have the highest death rate and shortest survival of any racial ethnic groups in the US for most cancers. Life expectancy is lower for Caucasians, males, and also women compared to the African American counterparts. Looking at this graph, the top pink line is Caucasian women, the bottom, the black line is African American women. The incidence of cancers is still higher in the Caucasian women. However, when you look at the mortality or the death rate below, the black line, which represents the African American women, the death rate is higher compared to the Caucasian women. Now I want to switch gear to cancer in the LGBTQ community. June is a Pride month, and so we want to celebrate LGBT community, and I thought this was the best time to talk about cancer in the LGBTQ community. There are over 1 million LGBTQ cancer survivors in this country. There's increased incidence, not because of sexual orientation. These disparities exist not because of biological or physiological differences between the LGBT people and heterosexual counterparts. Rather, the disparities are caused by a combination of social, economic factors and behaviors, and many of which can be traced to stress of living as a gender sexual minority in this country. This is based on common estimate that approximately 4% of the population is LGBTQ community. And they are not being represented in our trials. They unfortunately also have these risk factors that can put someone at a risk for developing breast cancer, such as cigarette smoking rates are higher, alcohol use is higher, obesity, they tend to be obese, and most of the women either don't want to have kids or don't have kids until after age 30. They report lower rates of mammography, colonoscopy, and pap smear compared to the heterosexual counterparts. Research studies have shown there's at least 7 types of cancer that disproportionately affects the LGBTQ population, and breast cancer is one of them. There's fear of discrimination. They've been discriminated in the past by healthcare providers. They don't have very affirming interactions with them. They may have had negative experiences in the past. They also have lower rate of health insurance because sometimes if you're married to the same-sex partner, some companies don't offer insurance. There's also been outright denial of care. 1 in 5 transgender patients have been turned away from health care. They may have limited financial access, and they may also have a perceived low risk of breast cancer. Transgender individuals receive lower quality of medical care, essentially because as healthcare professionals, we lack necessary knowledge about transgender identity and sexuality. There's 33 states that have no laws ensuring LGBTQ inclusive health insurance protections. Often they are victims of stigma from gay, lesbian, and heterosexual communities. And research and breast cancer risk, there's low numbers for us to actually make any kind of definitive conclusion. They also experience disparity when it comes to cancer survivorship, and they also have poor quality of life and cancer outcomes, unfortunately. They're less likely to have healthcare insurance, as most employers do not offer coverage for unmarried domestic partners. Even when cost is not a factor, previous or feared negative experience that they've had in the past, it keeps them from coming back for their routine screenings. There is provider insensitivity and ignorance that follows from the unwelcome that starts in the waiting room with the magazines and the medical forms that do not match their lives. LGBTQ cancer survivors, they report greater distress and more relationship difficulties, and they may engage in substance abuse and lower satisfaction in cancer care. So before we understand how to decrease disparity or opportunities to decrease disparity, I want to talk about something, equality and equity. What does it mean? Well, equality has to do with giving everyone the same exact resources. Well, we are not all the same. And equity involves distributing resources based on the needs of the recipients. So we really want to aim for equity where we are being impartial and even-handed with everyone and giving respect to individual differences. So no one should be at a disadvantage in their fight against cancer because of how much money they make, the color of their skin, their sexual orientation, their gender identity, their disability status, or where they live. There are several opportunities to decrease disparities. I want to make sure we educate our African American women about breast cancer outcomes. We want to work with our health systems to improve patient-physician communication. We want to get better, continue to promote screenings, but focus on improving the follow-up care in African Americans. We need to remove myths such as breast cancer is a white disease. If I don't have family history of breast cancer, I won't get it. We saw that 85% of the time, women don't have family history of breast cancer. Young African American women think they don't get breast cancer. And we also need to focus on survivorship for those who are already diagnosed with cancer. We have excellent survivorship at Ohio Health that covers physical, psychological, and economic issues of cancer, from diagnosis to the end of life, prevention, detection of new cancers, and recurrent cancer. We also have surveillance for cancer spread, recurrence, or second cancers. We are able to coordinate between specialists and primary care doctors to ensure that all the survivors' health needs are met. We have a patient navigator. They are nurses who act as liaisons between the patient and the breast health team. These people are the best, and they really help improve outcomes by being that constant support. They identify barriers amongst our patients, whether it's social, economic, inequality, fear of cost or pain, or avoidance of bad news. We need to remove barriers to screening. We need to increase access to screening and care for these patients. We need to remove financial burdens. We need to address the cultural and language differences. We need to educate women about breast cancer risks and screening methods. Health institutions such as ours and other institutions, we should actively convey that LGBTQ welcoming behavior, and that must be a core expectation of all the staff. Until all the healthcare facilities and providers become knowledgeable and respectful and safe, and free screening services will continue to be underutilized. So what are some opportunities to decrease disparities? Well, everyone has a fair and just opportunity to prevent, find, treat, and survive cancer. So I'm proud to say at Ohio Health, one of the core values is diversity and inclusion. Access to healthcare involving the LGBTQ community has grown drastically. We have entire network of physicians, associates, and providers who are dedicated to serving the community's needs and providing a safe environment. We believe in the basic principle that all people, despite race, ethnicity, gender, sex, religion, geographic location, or sexual orientation, have equal opportunity to lead healthy lives. So I came up with this recipe to decrease disparity. It's basically a mnemonic. R stands for removing barriers and to enroll in research trials. We really need to be proactive about getting into research trials. Otherwise, we are not going to know if certain drugs work in our population. We need to educate ourselves. E is for education. Education is very powerful. And not just you educate yourself, but you also help others get educated about the disease process, about what you're going through currently. You really want to collaborate with your PCPs, with your OBGYNs, with your specialists. We are all a team. We all work together as a team. And you have to trust us. And if there is something that we don't know or we don't have the knowledge of, educate us and teach us. We are humble enough to tell you that we don't know everything. We are still learning. I've been very humbled by this talk. I learned so much. You want to be proactive to investigate any health problems, and that's I. It's important to be your own advocate. No one is going to be your own advocate. You have to be your own advocate. P stands for prevention and screening measures. Make sure, figure out what things you can do to prevent. And I'm going to talk about that in just a little bit for breast cancer as well as screenings. And E stands for empowering others. And that's really, really important. We want to empower others. We want to make everyone have that inclusion, and they want to feel included. So speaking of prevention, I want to just talk briefly about prevention. Can we prevent breast cancer? Well, I did say 85 to 90% of the breast cancer is sporadic. Some of the factors that are associated with that could be overweight, a BMI of over 25, especially in the postmenopausal time, eating unhealthy food, or lack of exercise. What exercise does is, besides giving you the endorphins, it also consumes and controls the blood sugars and limits the insulin-like growth factor. And it affects how breast cancer cells grow and behave. And drinking alcohol, which also raises the estrogen levels, it can damage the DNA. Just have moderation in drinking alcohol. Smoking is linked to several cancers, including breast cancer. There are things we can control. Of course, there's things we cannot control, like our family history. We cannot control if you had radiation to the chest, if you've had a previous abnormal biopsy, or ethnic origin, the color of our skin, or sexual status, where we live, the reproductive factors, whether when we had our periods or when someone had menopause. But things we can do is we can control the obesity by exercising, keeping that BMI in the normal range. And American Cancer Society recommends 30 minutes a day, 5 days a week of any brisk walking is great. You don't have to be running a marathon. Having kids, maybe, if you're thinking of having kids, but possibly having them before 30. Breastfeeding, if you're able to. American Cancer Society recommends breastfeeding more than a year to reduce your risk of breast cancer. Alcohol, no more than 2 drinks a week is what some studies have shown. And American Cancer Society does say 1 drink a day for men and 2 drinks a day per man and 1 drink a day for women. But I think moderation is the key, and I say usually no more than 2 drinks per week for women. Also, hormone replacement therapy is a combination of estrogen, progesterone. As someone is taking during menopause, maybe take it for a shorter period of time or find different ways to cope with the side effects of menopause. And for those transgender people, just make sure they are knowing the risks of taking the hormone replacement therapy, whether it's combination of estrogen, progesterone, or testosterone. And we already talked about exercising. Exercising half an hour a day, 5 days a week is what's recommended by American Cancer Society. Let's talk about detecting breast and chest cancer. Well, studies have shown mammography is a very well-studied modality. There are a number of prospective studies that show mammography decreases the death rate and catches cancer early on. So I also recommend our patient population to do a self-breast chest awareness. Make sure you're checking yourself if you're premenopausal, a week after your period, if you're postmenopausal, same time every month. And if you belong to the LGBTQ community, just once a month, the same time every month. And make sure you check yourself. By looking in the mirror, you want to make sure you're looking for that redness, that puckering, the pulling of the skin. And you also want to put your arms up, checking for pulling, puckering, redness. You lay down, use the 3 pads of your fingers, and you go in a circle and to feel for any masses that feels like a rock or a marble. You also want to gently squeeze the nipple for any bloody or clear nipple discharge because that could be associated with breast cancer. And you also want to check underneath your arms to make sure there's no enlarged lymph nodes. And I did a talk a couple of months ago on screening and prevention. That's also on our Ohio Health website, where I do go into much more detail about a physical exam. And why is screening so important? If you get regular routine screenings, you'll be able to find breast cancer when it's the size of a pea. If you don't do regular breast exams, it will be a size of an almond before you find it. Unfortunately, that means you will need more surgeries, may need chemotherapy, and so earlier detection does save lives, and it improves chances of successful treatment with maybe a lumpectomy, just removing the tumor, rather than a mastectomy, which is removing the whole entire breast. And sometimes small tumors don't need chemotherapy. It reduces the need of extensive lymph node dissection. And we've come a far ways in our surgical world where we do lesser and lesser surgeries for our patients. And there's a number of different guidelines or recommendations of when one should start getting a screening mammogram. And the consensus is with Ohio Health, we follow the NCCN guidelines, and we're affiliated with MD Anderson. So we recommend for all those cisgender women, cisgender meaning women who are identified as female at birth, starting their mammography, starting at age 40 if you do not have any family history of breast cancer, meaning you're considered average risk for getting breast cancer. For those cisgender men, you're going from being a female to men, and if you've not had top surgery, you follow the same guidelines. But for cisgender women, you start imaging or mammography starting at age 50. And really, we don't have a good data. We're just kind of going off of what we know. We follow the NCCN guidelines. You obviously always want to be very aware of your chest and breast. If there's any masses that feel worrisome, always let your doctor know. Again, going back to my recipe to decrease disparity, R stands for removing barriers, involving in research studies. E stands for education. Educate yourself of not just breast cancer, all cancers, and educate yourself on what things are available for you. Collaborate with us, educate us. We want to know, we want to learn, and correct us if you say something that's wrong. We are willing to learn as from a provider standpoint of view. I stands for investigation. Investigate any health problems. Don't wait till tomorrow or the next day or the next year because things don't get better by themselves. Cancer doesn't go away if you don't treat it. P is prevention. Know all those things that you can do in your power that you can prevent. Life is not perfect. Nothing is 100% in our hands. But if there are things we can prevent, like exercising, keeping your body mass index, not smoking, alcohol in moderation, those things are in your control. And it's always good when you learn something. E stands for empowering others. We want to educate others. We want to empower others. When we learn something, share and help others. So in conclusion, access to quality health care should be a right for everyone. And going back to Jenny and Marianne, we at Ohio Health, we are very dedicated to advancing health equity and reducing cancer disparity by increasing access to cancer prevention, detection, treatment, and survivorship. We are committed to addressing the social determinants of health, mixture of social, economic, environmental, cultural health systems, and factors historically linked to discrimination or exclusion. We here at Ohio Health want to reach everyone, and we want to see you all in your full health potential. Thank you so much for joining tonight. I know it's hard to do it on a weeknight in the evening when it's time to be with your families. Here are my references. And it takes all of us, it takes a huge team to work towards a common goal to achieve health equity and to eliminate health disparity and to improve the health of all groups, no matter the color of their skin, their gender, their sexual identity, their ethnic groups. And I really love Mahatma Gandhi, who said the best way to find yourself is to be in service of others. And I found that to be true for myself. And thank you again for everyone who's attended tonight. Visit ohiohealthcancerwellness.eventbrite.com to register for our next event. And my next event is going to be talking about, do you know your risk for breast cancer? And I'm really super excited about this. And it's on Wednesday, October 6th from 5:30 to 6:30, and we will be advertising it. And please visit ohiohealth.com, health and wellness /LGBTQ healthcare for more information. You can also go to Cancer Care or call 614-566-4321 for any questions about Ohio Health. I can take any questions in the chat.
All right, thank you for that presentation, Dr. Halaharvi. Hello, my name is Tim Pilata, and I'm a marketing specialist at Ohio Health. We are going to move into the Q&A section of our event this evening. So if you haven't already, if you have any questions for Dr. Halaharvi, go ahead and put those into the chat at this time. And we'd also like to bring in our guest this evening, Dr. Lucy Bucher. Thank you for joining us. All right, so let's get into our questions. So Dr. Halaharvi, we'll start with you, and then we'll move over to Dr. Bucher for a response as well for each of these questions. So first up, we have a question from the chat that says, what are some ways that the LGBTQ community can advocate for themselves?
What are some ways to advocate for themselves? Obviously, all the things that I talked about, anything regarding the health, if making sure they're seeing their primary care physician on a regular basis, and talking about the different screenings, whether it's breast cancer screening, prostate screening, colon screening, and just finding out, what things that they need to do. And things also differ depending on whether they're transgender female or male, or if they're taking hormone replacement therapy. Those things do make a difference in what kind of screening prevention that. But I would say the first place to start with is the primary care physician.
All right, and Dr. Bucher?
I would have to agree with that. I think that finding a physician that you're comfortable with, somebody that you have good rapport with, somebody that understands where you're coming from and can help you find other specialists when you have things that need addressed, that is a really important thing for any of us, but especially for people who are notoriously underrepresented and don't have good access to health care and suffer from inequity in health care. Finding that sort of rock in your healthcare journey to help sort of guide you and be a support for you is really important.
Excellent, thank you. Our next question is, if someone isn't part of the African American or LGBTQ community, what are ways that they can continue to bring awareness to the topics we've talked about this evening?
I think I would think this talk is not just, I especially spoke for the African American community and the LGBTQ community, but this is talk for everyone. We just need to be our own advocates. And so knowing your risk for breast cancer, are you at average risk or high risk? Knowing when one should start getting imaging or mammography. For women who are average risk, should start at age 40. If they have family history of breast cancer, then you would start 10 years earlier than your family member.
All right, Dr. Bucher, anything to add there?
No, I mean, I think a way to kind of keep this in the forefront is what we're doing here tonight, right? We're talking about this, we're naming it, we're saying it out loud, and making sure that your friends, your family members, your coworkers, if you're, going to see your doctor or whatever, make sure that they've got someone that they're seeing, or that they, aren't having any barriers, and help them through that. I think just continuing to be saying things out loud and talking about it is important for the awareness and visibility.
I do agree with Dr. Booker. I think patients need to feel comfortable with their primary care providers. And like I said in my talk, I want to learn, we want to know more how we can help. And we want you to feel inclusive. And there's things that we need to learn. Please educate us and let us know. And she makes a really great point about finding someone you trust. And I think that's the most important thing. If you go to a physician you don't trust or don't have that trust with them, maybe find a different physician. But it's important to have that trust.
Our next question, what advice would you give to someone who feels they aren't getting equal health care or equitable health care?
I would have them, and like I talked about, collaborating between your primary care physician and maybe reaching out to the hospital to see who you can talk at the hospital. And Dr. Bucher may have better answers to that, and I'll let you answer.
No, I mean, I think if you have a good relationship with your physician, you can start there and say, this is what I'm experiencing and these are the barriers. But all of the offices and the healthcare systems and the hospitals have ways of the public contacting them to express concerns in either quality, patient safety, and we take those things exceptionally seriously. When patients come in with a complaint or call in or write a letter, we look into it. And so I think you need to say those things out loud and let people know that that's how you're feeling, because we might uncover something we didn't know what was happening, or B, we might understand better where people are coming from and can address that. So I think it's important. And it's hard sometimes to advocate for yourself. Unfortunately, over the past year, it's been hard to have family members with you at healthcare visits. But if you have a trusted friend or family member who can come to visits with you to be a second set of ears and eyes, or even just call in on the phone or review your discharge paperwork with you, I think that's really helpful, because there's so much information that sometimes is transmitted that it's nice to have another person who is a loving and supporting person for you to be able there to help digest that information.
So we have another question from the chat. So if a transgender individual identifies as a male, how can we ensure that they continue their breast health exams?
So it really depends on if the transgender male has undergone top surgery. And so if the transgender male has not undergone top surgery, then their screening recommendations would be identical to a cisgender woman. So it would be starting at age 40 if your average risk for breast cancer. But if you're a family member with breast cancer, then you would start 10 years earlier than the family member.
All right, and what resources do we have at Ohio Health for LGBTQ patients?
I think there is a link that we put at the end of my talk. If you click on the link, I believe there's a lot of resources available there. Dr. Bucher, do you have anything to add to that?
Yeah, so that link that's in the end of the talk does have a list of affirming physicians as well as services that are provided through the Ohio Health system. These range from family physicians, primary care physicians, as well as surgeons, subspecialist surgeons working in all areas of LGBTQ healthcare at all ages too. So it's a really nice website.
All right. And if someone has a family history of breast cancer, when would you recommend that they undergo genetic testing?
So if someone has family history of breast cancer, really depends on how many family members, how many first-degree relatives are diagnosed. If you have more than 2 first-degree relatives, or a family history of breast cancer, family history of ovarian cancer, or metastatic family history of prostate cancer. Those are all indications, or a male breast cancer. These are all indications for genetic testing. It really depends on how many members in your family have had breast cancer. And they can always call our Ohio Health 566-GENE, I believe is the number to dial. Ask any questions with our genetic counselors. And we have very robust genetic counselors in our system.
All right, and another question, and I would like both for Dr. Halaharvi and Dr. Booker to answer this. So what does pride mean to you?
So pride means to me a promotion of self-affirmation with dignity and equality and visibility of all gay, lesbian, heterosexual, homosexual, bisexual. It doesn't matter what you are, who you are, but it just means that we just give them back their pride and their dignity.
Pride to me is a celebration of love and loving other humans and letting other humans love who they want to love and letting them be who they want to be in all of their glory, and kind of accepting and loving people for just being a human race. We're all one people. And yeah, and I have family members and friends who fall within the spectrum of the LGBTQ community, and it's about celebrating them and having their time too.
All right. I think we can go ahead and wrap up the Q&A session this evening. So thank you so much for joining us, Dr. Booker. And thank you, everyone, for putting your questions into the chat. And I'm going to hand things back over to Dr. Halaharvi to wrap up for us this evening.
Thank you all for attending this evening. Visit ohiohealthcancerwellness.eventbrite.com to register for our next event. And I'm super excited about this next event. It's going to be, do you know your risk for breast cancer? And again, that's on October 6th on Wednesday from 5:30 to 6:30. And you'd want to visit ohiohealth.com, health and wellness/LGBTQ healthcare for more information, any questions that you may have about what we offer at Ohio Health. And of course, you can always call Cancer Care, which is 614-566-4321. Thank you so much for attending this evening.